Hi, everyone. Hi, Dr. Menn. I am Rachel, your host and community manager here at Alloy Health. For those who might be new, Alloy is a digital health platform bringing evidence-based menopause hormonal solutions direct to your door. Our mission is simple: to make sure women get the care they deserve during perimenopause, menopause, and beyond. Today, we are joined by none other than the extraordinary Dr. Corinne Menn, Alloy's Director of Clinical Innovation and Education, as well as Alloy prescribing physician and advocate. Before we dive in, I want to invite everyone to drop your questions for Dr. Menn into the Q&A. As always, I'll facilitate those a bit later. And because we want these conversations to feel supportive beyond this moment, if you're ready for next steps, we'd love for you to take advantage of today's discount code MEN20, as you saw on the banner before we got started. Hi again, Dr. Menn.
Hi, Rachel.
Hi,
To be
so
here.
happy to be with you. Thank you. Thank you for being here. I have wanted to have this conversation with you for quite a long time. I'm so glad that we're finally getting into it. It is your life's work, layered in with many, many other things that you talk about, and there's just no one better. I felt that we should launch this conversation with and keep it going with than you. Breast health and hormones are two words that make a lot of women very tense. Hormones and breast tissue have a complex, sort of context dependent relationship, and safe is, I think, rarely absolute. There's a lot of fear and confusion and worry. So I want us to really get to what's real, what's safe, and how women can actually feel empowered and confident to make decisions about what's best for them. So to begin, if you would ground us in some truth. We hear messages, some say hormones cause breast cancer, others say hormones protect against breast cancer. Can you walk us through what's actually true, or at least what's true for most women?
Yeah. Well, so that's a lot.
I know, sorry.
So,
I'm
okay.
start wherever you want.
Yeah. So let's start with some basics and let's just admit what we know is a huge problem out there is that the fear of breast cancer is causing a barrier for both women to make decisions and to access hormone therapy. And it's a barrier for physicians who want to do well by their patients, but they're not educated about menopause or hormone therapy. And there's a lot of fear. And so it's really important for women to know that at Alloy and all the doctors who, I work with at Alloy and everybody in my kind of world of menopause advocacy and, breast health, we practice evidence-based medicine, right? We follow guidelines, we read the literature, and here's what I can tell women from my decades of experience, as well as all of the literature, right? And I always kind of lean back onto our medical society guidelines, which kind of just help take all of this information and put it in a clear form. So number one, for the vast majority of women, particularly women who are perimenopausal in the first 10 years of menopause, menopausal hormone therapy benefits far outweigh the risks in general, right? That's number one. Number two, most of our data and most of the information that we get about breast cancer risk associated with hormones comes out of this big study, the Women's Health Initiative. Now we could have an hour-long conversation on all of the ins and outs. But, the bottom line is it was a $2 billion study to today's kind of money standards. And it was the largest study ever done on menopausal hormone therapy. And so we have an incredible amount of safety data. It just had a very bad PR campaign, okay? So over 20 years ago, a lot of fears were created because the study was stopped short. And the message went out that there was a risk of breast cancer. So what the primary investigators to this day now say, and we are all in agreement on, is that when women took estrogen alone, women who did not have a uterus, they had a lower risk of getting breast cancer and a lower risk of dying of breast cancer. So the estrogen alone has never in any study been shown to increase the risk of breast cancer, particularly in the largest study ever done. And then in the arm of the study where women had a uterus and you had to give them an estrogen with a progestin, in that arm of the study, there was a tiny, and when I say tiny, I mean tiny, increased risk of being diagnosed with breast cancer, which if we take it face value, just to keep it simple, the risk went from 3 in 1,000 women, like the baseline, to 3.8.
Wow.
Right. So that was reported to the public as a 26% increased risk.
Wow.
26% is a relative risk. The absolute risk was for every 1,000 women taking hormone therapy, there was a 0.8 additional diagnosis of breast cancer. Now, that is with the formulation that was used in the study, which was an estrogen with a medroxyprogesterone acetate, a synthetic progestin that is in some formulations of hormone therapy. It's not what we typically use these days, right? So that's one thing to keep in mind. So formulation may matter. Number two, it was such a small risk that it did not actually meet statistical significance, although they reported it as such. So again, very tiny, considered rare if you even believe the interpretation. And so I'll present it as they did, right? Tiny. So that's where this fear comes from, right? About estrogen, right? But remember, it was the arm of the study that did not have estrogen, that they were taking an estrogen plus a progestin. So that's where a lot of the fear, it's always good to know, like, where did this fear come from, all right? So then fast forward, we've had now 20 years of follow-up from that study and other observational studies and smaller randomized studies and other data points. And the Menopause Society guidelines is what, for clear messaging, I go back to, right? And they state what I just said. And they also state, which is really important, that the preponderance of evidence tells us that menopausal hormone therapy does not further increase your risk due to other factors. Meaning, because this is a lot of the questions we get, a family history of breast cancer, dense breasts, fibrocystic breasts, other reasons why you might have a higher risk of breast cancer, right? And we can talk about some of those in a minute. So I like to remind women that breast cancer in midlife is one of the most common cancers. 1 in 8 women will get it by the age of 80, right? So if somebody has breast cancer or got breast cancer, after being on hormone therapy, or maybe after never being on hormone therapy, right, it's not surprising because it's out there, right? So it's common, right? And so whether you take hormone therapy or not, it doesn't appear that it's going to cause breast cancer. Theoretically, if you have a breast cancer that is sitting in your breast that you've not been diagnosed with, right? And then you're given hormone therapy, and that breast cancer has some estrogen receptors on it, could additional estrogen, maybe you're menopausal at this point, stimulate a little growth, perhaps, and maybe you found it a little bit earlier because of that. But here's the really interesting news. Out of the largest study we ever did on this, it showed that even in women who were diagnosed while on hormone therapy, their breast cancers tended to be less aggressive, a lower stage, and they did not have an increased risk of dying. The study never showed that it increased the risk of dying. And women are more than just their breasts. We have to think about benefits, right? So quality of life, the other benefits to hormone therapy, like lowering your risk of osteoporosis. So I always like to tell women, I understand why you're afraid, but the talking points don't meet the reality.
Yeah.
So that was a lot, but at least
it's a lot, but
it's a little opening to get us kind of just grounded. Then we can get into some of those details.
And we will, and it's incredibly helpful and sort of rational making, right?
Yeah, let's just be rational. And I am a breast cancer survivor. I want anybody listening to know from the beginning, I take this seriously. I am not here to sell you estrogen. I do not get paid at Alloy based on how many prescriptions I write. We get, we consult with patients and we give them the best evidence-based, recommendations for them, right? Yeah. So we have to take the fear and we just have to look at you and say, what are your symptoms? What are you interested in for hormone therapy? Is it a good choice for you? But this overriding fear of breast cancer should not be the primary reason that we're making decisions, right?
Yeah. For what it's worth, And you let me know if this is not the time or place to
Yeah.
answer this question. What is happening inside the breast tissue itself when estrogen or progesterone are present? What's the real sort of interaction there?
So really important, estrogen, progesterone, and testosterone. These are all hormones that our ovaries make. And when we go through puberty as women born with ovaries, you know, estrogen is the driver along with these other hormones on breast development, the ducts and the lobules. It allows you to develop all your secondary sex characteristics. It allows you to breastfeed a baby, right? Estrogen is also, there are estrogen receptors on every cell of your body, your brains, in your skin, your GI tract, your bones, your muscles, etc. Right? So that's really important to understand that estrogen is a vital hormone that's with you all of your life, and it rises and it falls in different places. So the way estrogen and progesterone work at the cellular level is very complex, right? And it really depends on the environment that the breast tissue is in. It depends on the amount of estrogen and progesterone. I like to tell patients estrogen and progesterone, as well as other hormones, make, they have like this beautiful little dance that they do throughout our lives that impact kind of the growth and what's happening there. And remember, when you go through menopause, everything goes down really low. Your ovaries stop producing it. You still make tiny, tiny amounts of something called estrone from your fat cells in your ovaries, and a little bit of testosterone that might get converted to very low amounts of estrone, but low, and by large, you have very, very little estrogen. And so breasts, as we go into menopause, get less dense, they're less tender, they're less fibrocystic, they become more fatty and less dense. Younger breasts are more dense, they're more biologically active because they've got hormones impacting them, right? And remember that the amount of hormones that we give the average woman in perimenopause or menopause in FDA-approved hormone therapy is much, much lower than the amount of estrogen that your ovaries are making during your reproductive years. Sometimes people hear HRT, they think high doses of estrogen, that's dangerous on the breast. It's actually much lower than what you would have cycled with or what you had in pregnancy.
And so much lower than the birth control pill, which so many women take for
Yeah.
years.
And so again, here's a great example of like the birth control pill has had a good PR campaign for a long time, although lately everyone's vilifying it, and we can get into that. But just so women understand, the estrogen in a birth control pill is the same in all birth control pills for the most part. It's ethinyl estradiol. What your ovaries produce is estradiol. So ethinyl estradiol is a version, right, that is made to be very, very potent enough that it can tell your brain hormones to stop telling your ovaries to ovulate, right? So it quiets down your own ovarian estrogen production. So it's giving you some estrogen, but it's a different estrogen, right? And it's very, very potent. And so it's not the same risks or side effects, than us giving much actually lower, less potent doses of really bioidentical estradiol in menopause.
Interesting. Dr. Menn, you brought up breast density several times. Why does it matter really in this context at all?
Well, so let's just talk about like risk factors for breast cancer and also just why we care about breast density in screening, right? So younger breasts tend to be denser than older menopausal breasts, but it's also a factor of genetics, right? And so some women just have very, very dense breasts. The biggest problem with dense breasts are that it's harder for us to detect small breast cancers, DCIS, calcifications, abnormalities, because the tissue is so dense that on mammography, it's harder to see, right? So that's one thing. And so women who have very dense breasts who are just getting mammograms, sometimes, their breast cancer could be delayed. Their detection of their breast cancer can be a bit delayed, right? There's some thought that certain forms of menopausal hormone therapy, particularly the older forms that we don't use as much anymore, which with the synthetic progestins, tend to have a more negative impact on increasing breast density, which then in turn can make it a little harder to detect, right? And so it's not entirely clear why we see a higher risk of breast cancer in women who have very dense breasts. Some of it may just be, certainly that they have more, because they have more dense breasts and less fatty tissue, that they literally have more breast tissue per se,
Right.
ducts and the lobules, there's more of it present, so that there's more chance that some of it can turn into cancer. So just kind of the presence of having more tissue makes the risk a little higher, right? And then also the problems with screening. And this is why, if you're told that, okay, everything's normal on your mammogram, now it's required by the FDA in all 50 states that women must be informed of their breast density. And so it's really interesting that the major societies that make recommendations on screening, they actually don't list breast density alone as a reason to have enhanced surveillance with, say, an MRI or a breast ultrasound. The American College of Radiology recommends that because they know, from their perspective, that they can see things better, right? I think some of the larger, including NCCN and, other important medical societies that make these kind of guidelines, is that the problem is that enhanced surveillance with ultrasounds, MRIs, it's a cost, and it's not always available in every community.
Right.
So, and even if it was available in every community, we don't necessarily even have enough radiologists and centers and such to do it. And then there's lots of insurance things. So it hasn't been like mandated that you must have enhanced surveillance. So what we want to tell our patients, you should know your breast density. And what we want to do is, do you have dense breasts, and do you have other risk factors for having a higher risk of breast cancer? Because we would take those things together and we can make a decision whether you personally should have enhanced surveillance. What does enhanced surveillance mean? It means something besides a mammogram. So you still do the mammogram. You don't get rid of the mammogram. You do the mammogram, and then you can add on typically a breast MRI, which is the more effective option. Or there's other modalities. You could do an ultrasound. If you do a mammogram, adding the ultrasound doesn't give you added value. The trade-off of enhanced surveillance is when you do more tests, you find more benign things, and you can have more testing or more false positives, right? So that's always a trade-off that we have to make. And that's why we don't universally say that all women with dense breasts must have MRIs, but it's something that has to be individualized. And it's confusing for women, I know. And that's why, if you are that person, I always recommend speaking to the breast radiologist, find out what they recommend, right? And then ask to be referred to a breast specialist or a breast surgeon, and they can evaluate your risk and see if you should have other things ordered.
Terrific. What does it mean, Dr. Menn, when we hear about you touched on this already, but if you would just expand a bit more, estrogen receptor positive or progesterone receptor positive breast cancers, and how does that affect future hormone use?
Yep, very important. So 70 to 80% of breast cancers are ER positive or estrogen receptor positive, and many of those are also progesterone receptor positive. And then there's another receptor we look at called HER2. So most breast cancers are ER/PR positive, and I'll focus mostly on estrogen receptor positive, right? And then there's a subset that is what we often call ER negative, or sometimes triple negative, because they're negative to all the receptors. So what that means, this is super important, because people think I have ER positive breast cancer, or my DCIS was ER positive. It means that estrogen caused my breast cancer. That's not true. That's overly simplistic language that sometimes is kind of casually thrown out there. You have always had estrogen receptors on your breasts. I don't have breasts anymore, but I'm a breast cancer survivor. I've had a bilateral mastectomy. But all women have estrogen receptors on their breasts, as well as on their skin and on their GI tract and bones, as we've said, right? So what happens when that normal breast cell that has a little receptor for estrogen on it and progesterone, right? So those little receptors, estrogen binds to that receptor and then tells the cell to do things. grow, change, etc., so that we can, have the function of breasts, right? And our bones, that estrogen receptor is, tells our bones to, hold on to our bone density, right? So when that cancer cell becomes cancerous, right? Sometimes that cancer cell still looks kind of like a normal breast cell and it expresses, or it still shows the estrogen receptors. Sometimes it overexpresses the estrogen receptors, meaning it makes even more estrogen receptors. And then it allows it to use estrogen for it to grow. That is very, very different than saying that estrogen caused, the cancer. And so for women who are dealing with an ER positive breast cancer, the reason why we stop estrogen or we use medications to block the estrogen receptor is because we're going to use that receptor to manipulate that cancer cell, kill it, keep it dormant, keep it quiet, shut it down, and then your immune system can take care of it as well. So it's a mainstay of ER positive breast cancer treatment. Triple negative patients where their cancer cells do not have the estrogen receptor, we can't use hormonal manipulation. So those patients, we have to rely on chemotherapy. And now there's some other newer medications that we could help those people with that, right? So that's kind of the down low on the estrogen receptor. Whether or not a patient could ever use systemic hormone therapy, we do take a look at, were they ER positive? Were they triple negative? What is their risk of recurrence? How far are they from diagnosis? Are they newly diagnosed in the middle of treatment? Are they far out? Did they only have DCIS and have had both breasts removed? Were they triple negative and have had years of normal periods and high estrogen levels, and now they're menopausal? So my point is just that your breast cancer is unique, and we can't lump all of us in one bucket when we have to have very hard conversations about what we should do about considering hormone therapy. So that's not a perfect answer, but
no, it is, because it's an honest answer, and everybody is different. And the conversation, I think, and this will happen, I believe, more and more around hormone therapy in general, will sort of be understood to be as nuanced as it really is, right?
Yeah.
And this is that as well. And information is always powerful and helpful. And the more that we have about our own bodies, the more confident we can feel making decisions about them.
Yes.
Dr. Menn, can you quickly, in 30 seconds, walk us through a breast self-exam?
Yeah. So, I encourage all women to every month to check your breasts, right? It does not replace getting screening when you're supposed to get screened. But if you're going to check your breasts, it's really important. I always tell women to start by looking in the mirror, right? Notice, are there skin changes? Is the contour a little different? Look with your arms at the sides. You can pick your arms up, kind of look, you just want to observe, right? Because, when you see something all the time and, every month you're looking and you'll know, your body best. You'll be like, wait, that nipple is indented a little bit, or there's a little puckering, or, something looks different in the contour. So that's the very first thing you want to do, right? Then you want to feel your breast. So I tell women, just going around a clock, start on the outside and go in a circle and get closer and closer to the nipple. That's one way you could do it. Or you could start at the nipple and kind of go out, and go all around the breast out. And I tell women, start with a light touch and then do another round with a deeper touch, right? Then definitely feel around the areola and around the nipple. I also tell women to feel up by the top of the breast by your clavicle, because there's little lymph nodes here and here, right? That could be swollen if there was something growing in the breast. And then also underneath your arm. So pick up your arm and kind of just relax it. I'm sorry, actually, if you pick it up, it makes it more tense. Just kind of keep it kind of more relaxed and down, so you're not tensing up the muscle, and feel up inside your armpit, because this is where the lymph nodes that drain your breast. So if you feel something tender or thickened or something not right there, you want to speak up. Don't write it off. People always ask, but Dr. Menn, my breasts are lumpy, bumpy. I feel all sorts of stuff there. Here's the thing. I can tell you, because I found my own lump myself. You will know if there's something growing there That's not supposed to be there. I promise you. But if you really want to know what it feels like for most people, go get a bag of frozen peas, right? And feel a bag of frozen peas, or take a few frozen peas, put in a little plastic bag and just feel it. That's what it feels like, generally speaking. Not always, but it's often reported as a non-tender. Breast cancer is very rarely painful, but of course, if you've got something painful in your breast, you need to speak that up too. Don't just write that off. Non-painful, generally smooth, and generally can be generally movable. You could kind of push it around. And you can generally find it again and again, right? Like sometimes breasts feel like very lumpy, bumpy, but I ask patients, can you find that same bump twice? And they're like, no. But if there's something growing there abnormally, you'll be able to find it again, right? And so those are some of the tips. And the other thing is, if you feel something and you bring it to your doctor and they don't feel it, it doesn't end there.
Okay.
You feel something and your doctor's like, well, I don't really feel it. You're like, well, I feel it. Be a squeaky wheel, be pushy. A couple of things: you're never too young for breast cancer, right? I'm part of the Young Survival Coalition. I was 28. Many women in the YSC have reported, and I've been part of them, involved with them for over 20 years. And to this day, I still see women being told they're too young. They were put off for a few months to a whole year. They were told, oh, well, you're breastfeeding, that's just a clogged milk duct, etc. Right? Follow it for a bunch of menstrual cycles. None of that should be, tolerated. Don't worry about, offending your doctor or asking for a referral. You have to be squeaky. I'd much rather investigate something and it, be a false alarm, right? So yeah, those are my tips there.
Thank you for that.
Well, one last thing about examining your breast. If you are having regular menstrual cycles, it's really ideal to check your breasts when your period is over, right? Like right towards the end of your period before you start up again, because that's when your breasts are the least cystic, the least tender, and it's actually the time when your estrogen levels are the lowest. So generally they're the least kind of tender and cystic. So that's, because there's a little campaign, feel it on the first, which is fine. It's a great reminder. All right, first of the month, I feel it. And you can do that, but you should also feel it when, okay, my period's done. This is a good time to check my breasts, like in the shower or something.
Yes. Super helpful. Dr. Menn, does the type of hormone matters in terms of breast safety? So for example, a patch versus a pill, gel, spray, and so on.
Yes. So, all right. So I think we have to separate that out. And so there's different formulations, meaning how we deliver the hormone. So patch, spray, pill, gel, even rings. But then there's the type of hormone. So let's talk about estrogen. So estrogen is a general term. And within estrogen, we've got bioidentical FDA approved estradiol, right? So the data that we have doesn't show any difference on whether that estradiol is given in a patch, a pill, a gel or a spray form in terms of breast cancer risk, right? When we talk about risk associated with that kind of formulation, it really has to do with cardiovascular and blood clot risk, right? So if someone is at a higher risk for blood clots, we're going to do something that goes via the skin, like a patch, spray, or gel, versus a pill, because when you do a pill, it has to be metabolized by the liver and it could raise clotting factors. But in terms of breast health, we don't see any studies showing any difference between that. That's number one. Number two is, it is important for women to understand that in the largest study, the WHI, the estrogen that was used was called conjugated equine estrogen, CEE. The brand name is Premarin, still in the market, and it's not a bad hormone. But people have generally moved away from that for various reasons. And most women these days are prescribed an estradiol, mainly because estradiol in general has a good safety profile. People feel good on it, and it's become the preference, right? The data on conjugated equine estrogen, or Premarin, is really interesting. And the estrogen alone arm of the WHI, women had a 23 to 26% lower risk of getting breast cancer and a 40% lower risk of dying of breast cancer.
Right.
we don't have the same level of data on estradiol. Observational studies, some other randomized controlled studies with estradiol suggests that estradiol alone may be similar in that it's either neutral or maybe a lower risk, but we are very careful. We can't say it across the board. So you'll hear estrogens talked about like they're one thing. They're really not. All right. So that's one thing to keep in mind, right? And then in terms of formulation, when we look at the progestins, this is why most people are on a progesterone, a bioidentical progesterone, because subsequent to the WHI, we really looked at the differences of the impact on the progestin on your body. And what we think we know, we're not 100% sure, but what we think we know is that the synthetic progestins, while still very safe and useful, I always say worst case scenario, it took you from 3 per 1,000 to 3.8 per 1,000, right? Very small. Or in other terms, we could say it took a woman with a lifetime risk, the average lifetime risk of using a progestin with estrogen went from 12 to 13% in your lifetime. So that's a 1 in 8 number. We hear if you make it till age 80, you got a 12 to 13% risk of getting breast cancer, regardless of whether you're on hormone therapy or not. And so, that risk goes up from 12 to 13% to maybe 14 to 15%, like a 1% perhaps, if you use that synthetic progestin, right? So these are small numbers, right? And so what the data has shown, it appears that progesterone, which doesn't look exactly like medroxyprogesterone acetate from a biochemical standpoint, appears at the very least breast neutral, right? We have no data showing that progesterone increases breast cancer risk. But because of the estrogen alone arm of this study, when women don't have a uterus, we counsel them that the safest on their breast appears to be estrogen alone.
Okay.
But we're not afraid to give you.
Yeah. And again, remember the numbers.
Yes, the numbers are very, very small, right? So it's really important, when we look at clinical studies and we look at drugs and safety, we take risks and we look at common, very common, rare, very rare, extremely rare, right? And so the elevated risk of breast cancer from the WHI was right on the border of rare and very rare. Okay, we are talking rare, right? But what's not rare is the help that people get when they use hormone therapy. And that it was so helpful for preventing osteoporosis that the FDA years ago put a indication. And I want everyone to think about this. This is really important. I don't think people understand this. I didn't understand this until, years later from becoming a doctor. But in order to get the approval to have something as prevention, it is a big deal, because that means that the FDA is saying to the country that this drug is so safe that we should give it to people who want to prevent disease from happening, versus very different, a drug getting approved for a disease label, right? Like, to treat, I don't know, anything, really anything, a heart issue, anything, right? So because that drug's only being prescribed for someone who has the problem. It is FDA approved for anybody, for a menopausal woman who wants to lower her risk of osteoporosis. Because unlike this very tiny increased risk of breast cancer that they saw maybe with the progestin arm of the study, 1 in 2 women will fracture a bone in her lifetime.
Right.
1 in 2 women will have osteoporosis. Hormone therapy cuts that in half. Okay.
Incredible.
Right. So, so people say well, I have a family history of breast cancer. I've never had breast cancer, but my aunt had osteoporosis. My mom broke her hip, grandma's in the hospital. She's had dementia for years. Again, it's not FDA approved for dementia, but we have a lot of data that says when we started early on that these women tend to have less dementia down the road. We should be able to talk to this woman and say, listen, your family history may raise your risk a little bit, and let's see what's the best screening for you. But we have to balance anything against the benefits that you might have for these other things. So that's how I want women to think. And that's how doctors need to think.
Yeah. Thank you for that. I'm going to turn in a moment to questions that have come in. We have
Yep.
several. I do, though, Dr. Menn, want to give you a couple of minutes to talk about vaginal estrogen and its safety and efficacy for any and all women. You talk about this a lot on your platform, and you're fervent and adamant about informing women about all of this, but dive in on vaginal estrogen for us.
Very, very important. We've got lots of forms of vaginal estrogen. The most common, economical, and really my favorite way to give it is a vaginal estrogen cream. Okay. It's a 0.01% estradiol FDA approved vaginal cream. The problem is that 20 years ago, when all of this messaging of the WHI went out, the FDA put a black box warning label and a package insert on any products that contained estrogen. And there was no differentiating between something that was a systemic hormone that went all throughout your body when you took it. That's what we think of HRT, MHT, right? And they didn't differentiate it from vaginal estrogen. So vaginal estrogen is not going to treat your hot flashes. It's not going to protect your bones. It's not going to do anything else for systemic things. But what it is going to do, it's extremely effective and very safe for treating the genitourinary syndrome of the menopause. So that's the vaginal dryness, decreased lubrication, painful sex, clitoral atrophy, vulvar atrophy, decreased sensation, so a lot of sexual function, as well as urinary symptoms, urinary tract infections, urinary urgency and frequency, right? So I like to tell patients, it's like this. You take a Benadryl pill, like if you have a bad allergies, right? If you have an itch on your hand, you put a little over-the-counter Benadryl cream, okay? The Benadryl cream is not going to make you fall asleep, because we know if you take oral Benadryl, you'll fall asleep, right? One's working systemically, one's working locally. Some women take prednisone orally because for a medical reason, there's lots of reasons. It's a systemic steroid. Other people go to the CVS and they get a little hydrocortisone cream and they put it on their skin for an itch. Systemic HRT is the same thing as that kind of comparison to local vaginal estrogen. Ladies, I don't care what medical condition you've had in your life. I don't care you had a massive stroke. I mean, I care. I don't want that to happen to you. Heart attack, some advanced cancer, a blood clotting disorder. I don't care. I don't care what it is. You can use vaginal hormones, right? We want you to use FDA approved hormones. They're very safe. They're highly effective. And if it's been many, many years and you're like, well, I'm past menopause, I don't have hot flashes anymore, but I still have some of these GSM symptoms, you could start at any time. You can take it for life. If you're taking an hormone therapy, you can use it along with your systemic hormone therapy. And if you have a mom or an aunt or a friend or a sister out there who's older and she's dealing with particularly urinary tract infections and some of these symptoms, it's never too late to start it. I write it routinely for an 80-year-old, an 85-year-old. The other day, I wrote it for a 90-year-old.
Yeah, awesome. Awesome. Okay. Yeah, thank
you.
you.
It doesn't increase your risk of breast cancer, but the problem is that package insert, that black box label, it says may cause cardiovascular disease, breast cancer, pulmonary embolus, and then they write improbable dementia. And so you give the patient their vaginal estrogen and they're like, well, thanks, Dr. Menn, but no thanks. I'm not interested in dementia.
And so many women have done that. They've gotten their tube and they open that incredibly long CVS length of warnings, receipt of warnings, and they're like, never mind. And it sits there.
And it sits there. And so that, again, the fear of breast cancer, again, and out of all those things, people fear the breast cancer the most and then dementia the second. Women don't fear the heart attacks, it seems. No one says, well, I don't want to take the vaginal estrogen with the heart attack. Like, that's the number one cause of death. But vaginal estrogen isn't going to cause that. And I'm so glad you brought it up because we might, actually, I'm 99% sure, the FDA is going to change that label. And I suspect it's going to be sooner rather than later. So if you hear that news hit, I want you to feel very assured that we support that label change at Alloy. The doctors here, Dr. Sharon Malone, our medical advisor, every doctor in this space, the Menopause Society, ACOG, have been begging the FDA for literally now decades to take that warning off of local low-dose vaginal estrogen, and frankly, to greatly modify and change the label on systemic hormones, because it doesn't reflect all that we know about hormone therapy, and it creates so many barriers.
And we're going to talk about that when it happens.
We are going to be, you are not going to get me to shut up.
Dr. Menn won't stop talking about it.
No.
Next question. I have a patient with a history of non-Hodgkin's lymphoma with radiation to the chest,
Yes.
23 years in remission. She's having a lot of menopause symptoms and would like hormone therapy. What thoughts do you have? I love that the doctor is here asking this question.
Yeah, this is a really important question because it speaks to the fact that there are many cancer survivors who, you know, are afraid of menopausal hormone therapy, and they didn't have breast cancer, right? So in this case, someone who had chest radiation at a younger age, right? They are at an elevated risk of breast cancer, 100%. We not 100% risk. I'm saying for sure there, we know that there's an increased risk there, right? And so in that case, it's very, very important, one, that that patient figures out with a breast specialist, what is her best surveillance plan? And it will depend on more than what the fact that she had radiation. It might depend on, did she have radiation, and what are, does she have other risk factors for breast cancer, right? I would treat that patient like I treat all of my patients who have varying degrees of breast cancer risk. We've got our average risk, which is the 1 in 8 in your lifetime. Someone with chest radiation is going to be elevated, not as elevated as someone who carries a BRCA mutation, which is going to be much higher, but somewhere in between, probably more on the lines of someone who has a family history, but they don't have the BRCA gene, or they have had atypical ductal hyperplasia, or some of these other breast biopsies that are not cancer, but just like raise their risk of having breast cancer in the future. So it's elevated, right? And so what I like to tell that patient is, you are not precluded from using menopausal hormone therapy. The preponderance of data, and this is exactly word for word from the Menopause Society position statement, the preponderance of evidence tells us that menopausal hormone therapy isn't going to further increase her risk. But in that patient, I would want her to be having some form of enhanced surveillance, whether or not I give her menopausal hormone therapy or not, right? And then particularly in these women who we know are at an elevated risk of breast cancer, we tend to always recommend using a progesterone, not a synthetic progestin. I might start with a lower dose, not that she can't have a higher dose, but I know that these women, we start low and we titrate up to find the dose that treats your symptoms and minimizes your side effects. Because, we know that, like, you give a higher dose of a menopausal hormone therapy and an estrogen, one of the common side effects is some breast tenderness in the first few months. And it's normal. We expect it. We give the same advice when we write a prescription for the birth control pill, and that tends to settle down over time. And it can also be dose related. But for someone who has a higher risk of breast cancer, it feels scary to them.
Sure.
Breasts feel tender, right? But I bet you that this woman asking this question, I bet you she's had doctors told her she should avoid hormone therapy, right?
Well, she was a doctor asking on behalf of a patient, and I'm guessing that yes, the patient has.
So, yeah. And so I would also say that it's really important that we counsel these patients on all of their risks of breast cancer. So we've got something we can't change. The patient had radiation therapy. There's some things that she can change. And some of these things are things that have probably a higher risk than me giving her menopausal hormone therapy. I would have her severely limit or just eliminate alcohol, because having extra alcohol in your life is going to raise your breast cancer risk more than menopausal hormone therapy. And alcohol gives you zero benefits. There's no benefit except for maybe you enjoy the taste and you have fun with your friends, but then you don't sleep that night, right? Menopausal hormone therapy has a less risk than alcohol and protects your bones, improves your quality of life, treats all these symptoms. I mean, if you started earlier, there may be benefits towards heart disease, etc. So which one would you rather like?
So glad you brought that up.
I'd rather eliminate the alcohol.
Yeah.
I tell her she can eliminate alcohol. She can really start to care about moving her body. She can move to a very plant-heavy diet. I eat meat. I think lean protein is important, but we want to fill our plate with a rainbow, lots of phytonutrients and fiber. focus on our sleep, get enhanced surveillance, and choose a great formula for your menopausal hormone therapy. But I would never use that to withhold a woman from getting help from her suffering.
Fantastic. Someone's asking, where can I get info on trials for women with a history of low-grade breast cancer and HRT? And I guess,
Oh, I'm so glad you asked.
yes.
Okay, so this is super important. It's already out there, and I'll put it, if people want to go to the link in my story, I'll put it in my stories today. So it's already live, and it's not behind a paywall, so anybody can look at this. So the Menopause Society just accepted publication of a paper that's going to be in the official January issue of Menopause. And it's a consensus statement that has been made with the help of many menopause specialists, breast oncologists, breast surgeons from in many places around the world. And they came up with a consensus statement on how we can talk about hormone therapy after breast cancer. But I bring it up because one very big part of this paper is that they are proposing, and they are moving forward with it, a study called MENO-ABC. And this is going to be a worldwide observational trial where women who have elected to use menopausal hormone therapy after breast cancer can sign its consent, and then with the help of their doctor, choose the hormone therapy of their choice. So it's not going to be a randomized controlled study, but it's a way for us to collect data on these women so that we can start to give these women some information, because the problem is all of the studies have been done. The last study that was done, randomized controlled study, and we're probably never going to have another RCT, was done, back around the WHI time.
Yeah.
So we really need new data. So this is very exciting. And so stay tuned, because we are going to do, I just spoke to the scientists on the paper. We're going to do some webinars for clinicians. We're going to do some social media stuff. And there's already a website where you can sign up with your email so that when the study information goes live, you will be the first to get it. You could bring it to your doctor.
Wow.
And so we can start to collect this data. So that's really important, number one. And along with that, in this paper, it's 23 pages of a beautiful explanation of what we know, what we don't know, and some basic consensus ideas of who might be better people to consider hormone therapy after breast cancer and who we might be more cautious with, knowing that none of it is perfect answers, but at least it's a framework.
Terrific.
It's literally just hot off the presses.
Yeah. Oh, that's so wonderful. I just want to pause for a moment. There are several more questions to get to. Can you give us an extra 15 minutes?
No, I can't.
No, I want to ask, and for those of you who do need to jump off, I will get to all your questions since Dr. Menn can stay with us. So be sure to look back and check out your answer. Next question. I'm allergic to soy protein. My doctor told me I cannot take HRT, MHT, because both estrogen and progesterone have soy in it. Is there any MHT that does not contain soy? She's already got her hand up. What are my options?
All right. So soy is a very common food allergy. I have been practicing menopause management for years. I have never in my life had a patient ever had an allergic reaction to menopausal hormone therapy because of a soy allergy, right? Honestly, just no. You can have hormone therapy, right? Because we are generally preferring estradiol and progesterone. All of these hormones are produced in labs. They're natural, yes, but they don't magically come out of nature. They are made in a lab. They use things like YAM and it's plant-based, but we're not picking the pill off the plant. Right. These are made in a lab, and someone who has a soy allergy, we're not sprinkling soy into this patch or this pill. So I think you're a very good candidate to use it. We don't prescribe Premarin or conjugated equine estrogen right now. We don't have it at Alloy because most women we're not prescribing that to. That is an option that comes from pregnant horse urine. I don't say that facetiously. I'm just letting you know that that's the source. So I don't think there's any soy-based product there. So maybe if your doctor is really afraid, they can prescribe you Premarin, or you can come to Alloy and we'll give you evidence-based care.
Terrific. Can you speak to and this one I think you've spoken about sort of throughout, and certainly we have lots of conversations you and I have had, you and myself and others have had answering this question. But if you can just briefly speak to the different types of MHT and what type is used mostly by women with a uterus.
If you have a uterus, you must use some form of progesterone. So you've got choices. Ideally, we love progesterone, so oral micronized progesterone. We never use progesterone in a cream form. There are telehealth companies out there that are prescribing progesterone cream. It is not recommended because progesterone creams are not absorbed well enough to protect that lining of the uterus. So when we give estrogen, there's a very, very rare risk of increasing uterine cancer if the estrogen can make the lining too thick. So oral progesterone, best choice for most people. Some people don't like it. They don't tolerate it. It makes it too sleepy. There's a synthetic progestin. We tend to use norethindrone or norethindrone acetate. So that's in an oral pill, right? There are patches on the market that have an estrogen with a synthetic progestin in it. The brand is called Combi patch. There are IUDs. So a Mirena IUD or a Liletta IUD, these have a progestin hormone. They are wonderful to protect the lining of the uterus. And then you could take whatever form of estrogen you need. They're also great. They give you birth control and they control bleeding. So that's another form of progestin or progesterone, right? So lots of choices. I'd say the most common by far is oral micronized progesterone. You take it at night and it helps you fall asleep. Most women love it.
I love it. Can you speak about using hormone therapy in an early menopausal onset female whose mother had endometrial cancer?
Yes. So endometrial cancer, sometimes can be associated with hereditary cancer syndromes. There are some, particularly something called Lynch syndrome. So if you look back and your mom was very young, she didn't have other risk factors for uterine cancer. There was multiple uterine cancers. There was also colon cancers in the family. You might want to see, oh, should I get genetic testing? But not to deny you hormone therapy, just to know what your risk is. But a lot of endometrial cancer comes from, the risks come from other factors. Unfortunately, living with obesity or being overweight is one of the risk factors. And having a long history of like very irregular periods where you don't always shed the lining can raise your risk. And there's other factors too. But a family history of endometrial cancer is not a contraindication for you having hormone therapy. Now, it sounds like this patient might have had early menopause, which is really important for us to be aware of. So if you had your menopause younger than age 40 or younger than age 45, is early menopause before age 40 is premature menopause. It is considered the standard of care that you must have full hormone replacement therapy up to the age of natural menopause at least, and then you can decide what you want to do for there. Because when we remove those hormones early, so if you had your ovaries removed or if you just went through early menopause for some other reason, we really need to replace your hormones. And that family history of uterine cancer should not make you afraid to take the hormones, but just kind of find out a little bit more just for your own health of, what was going on with that uterine cancer risk.
Okay. I'm a menopause coaching specialist. I have a client scared to take MHT as she has had a heart surgery. Is she a candidate for MHT? And can you literally cut a patch in half if your doctor says cut estrogen dose in half without prescribing a new dose?
Yes. So the second part of the question is easy. So the patches that we change twice a week, okay, they're matrix dot patches. They can be cut. The manufacturer label will say do not cut,
Right.
but they're stable to cut. I do it all the time with patients, especially if they had some breast tenderness or some bleeding and we wanted to just quickly cut it down and they don't have to get a new prescription, right? So you can cut a patch. The patches that are weekly patches, you can't cut them. It's not as stable that you can't cut those. But the twice a week patches most patients have, you can cut. Cardiovascular disease is really important. It really depends on the cardiovascular disease, the age of the patient, and the context. And it's very interesting, and anybody can Google this, go look it up. It's called the British Menopause Society has a practice guide on managing MHT after cardiovascular disease, and they have another statement on managing menopause and MHT after a heart attack. And it's really interesting. We don't have big long-term randomized controlled studies on this, but we do have data points on this. And what they have found is that unless there's some other true contraindication, women who have actually had heart attacks actually do better
Yeah.
and are less likely to have a repeat heart attack if they're given menopausal hormone therapy, but we would stick with a transdermal estrogen. We would not give oral estrogen. We would avoid synthetic progestins. But a more complicated cardiovascular history is not an absolute contraindication. It really has to be taken into context. Now, someone who has not been on hormone therapy for many years, and then they have a stroke or a big heart attack, and then they want to start hormone therapy, they're over 60, 65 years old, that gets a little bit more complicated. But in the younger menopausal woman, she can consider that. And I always point doctors or someone who's helping patients navigate things, because the British Menopause Society just did such a beautiful statement on it. And if you look back, I have lots of reels on this because it's another population of patients that are dismissed.
Yes, and underserved. This question I actually was going to ask as it relates to Alloy specifically and why we have a mammogram requirement. But this person asks, is it mandatory to have a mammogram before a doctor can prescribe MHT? And what about having a breast MRI instead?
Couple things. So the reason why we recommend that all women have guideline, suggested mammograms is because we're practicing good medicine. We want American College of OBGYN, we follow their guidelines. And it's recommended the average risk patient begins mammogram screening at the age of 40 and gets it at least every 2 years. Personally, I recommend to my patients every year, but at Alloy, we're asking you to at least get your mammogram every 2 years, right? Now, we have patients who come to us mainly because they don't have easy access to doctors. They can't get in with their doctor, lack of access. And so they may be behind on their mammograms and they're still suffering with their hot flashes. And so we tell patients like, here, we can get you started on hormone therapy, right? We'd love for you to have your mammogram up to date at the get-go. So we know we're starting with a nice clean mammogram, but and we're not asking you to take the mammogram because we think what we're giving you is going to cause you to get breast cancer, right? But I always want to know if someone has an underlying breast cancer that they don't even know about. I'd like to know about that before I gave them estrogen. So I think our policy is really fair in that we say, like, listen, we'll write you a prescription for 3 months supply. Why don't you get your mammogram up to date? I've had a few patients where, it took them beyond 3 months. And so we gave them another refill. Like, we're not unreasonable human beings.
Right.
Some doctors, not all, because this is at the discretion of the physician. If you are truly against having a mammogram and the doctor feels like they've given you an informed discussion and said, here's the benefits, of getting a mammogram versus the risks. And what we know is that mammograms do save lives, and it catches breast cancers early. But some doctors may say, okay, you've been counseled, you can sign a waiver and I will prescribe hormone therapy for you. So again, it's not a promise, it's an option, and you can work with your doctor on that. I often like to turn around and say, why don't you want to get a mammogram? Maybe we can use this as an education opportunity, or say, like, let's think about, like, why are you, not wanting to get. Now, MRIs, we don't generally do an MRI only, although if you've had a recent breast MRI, that is great screening. Typically, someone who's getting enhanced surveillance, they're alternating. They're getting the mammogram, and then they're alternating with a breast MRI. If you're only getting a breast MRI, just let your Alloy doctor know that, and we'll figure that out. Some things that do not count as screening: an ultrasound alone,
Okay.
thermography, QT imaging. These are not, they don't replace mammograms. And people say, well, why? The ultrasound is so good for dense breasts, Dr. Menn. I've been told ultrasound, that's really good for dense breasts. You're right. An ultrasound will pick up a larger cyst or something that can be totally obscured from in a mammogram. But guess what the ultrasound will not pick up? The ultrasound will not pick up microcalcifications. It will not pick up DCIS. It will not pick up a small breast cancer. And let me remind patients that small does not mean always early or less aggressive, and big does not always mean bad. So that might be a little confusing the way I said that. So There are small triple negative breast cancers or triple positive breast cancers or grade 3 fast growing breast cancers that are very, very tiny. And we pick them up early, and thank God we do. Because if we waited until they showed up on a thermography, where thermography just picks up heat, or on some other modality like an ultrasound, if you wait for it to pick it, that aggressive cancer is probably going to be in your lymph nodes and maybe in your bones or elsewhere, metastatic, right? So that's why we want to get things early, because some very advanced breast cancers, in terms of its aggressiveness, I should say, not, can be very, very tiny and will be completely missed on an ultrasound, right?
Yeah.
And so that is really, really important for people to understand. And there's a lot of misinformation on social media, unfortunately. A lot of people are hearing, don't get a mammogram, do this instead. I always tell patients, if you hear that message from somebody, the first thing I want you to do is ask yourself, who is giving that message? Look at their medical credentials. Are they a coach? Are they a naturopath? Are they a chiropractor? Are they a functional medicine specialist? There are many people in all 4 of those categories who are excellent in doing good work, but they stay in their lane.
Mm-hmm.
Okay. You have to ask them, what are your credentials in telling me this, right? And then the next thing is why are they prescribing this form? Are they offering the thermography in their clinic and charging cash because your insurance isn't going to cover thermography?
Right.
Are they charging you extra for the QT imaging? Are they telling you not to do the mammogram and instead do their detox cleanse? And then that's better. So I want you to ask yourself those questions if someone is telling you not to get breast cancer screening. I mean, I'm serious.
You're emphatic for a reason.
Yeah.
You actually answered just now this last question, so I'm going to skip to the next. Can you speak about, you did a bit, but a woman with extremely dense breast tissue who is also using MHT, should she ask for additional testing as well as her yearly mammogram? She has no other risk factors.
So this is so this gets back to knowing what your risk actually is. So there's a couple ways you could do this. Very, very dense breasts, at the very minimum, I would order an ultrasound. But what I would really want to do, and we like to do this by age 30 for all women, and then continue in after, is periodically check in with a risk calculator. There's one that is free online. Olivia Munn is out there talking about it a lot. If you know her breast cancer story, the Tyrer-Cuzick risk calculator, you plug in a very comprehensive family history, things about your lifestyle, things about when your period started, how many babies you've had, all of these different factors. And it gives you a lifetime risk of breast cancer and a 5-year risk of breast cancer. And based on that, it will tell you a couple of things. Do you meet criteria for being referred for genetic testing, or do you meet criteria for having enhanced surveillance? Because breast density alone sometimes doesn't meet that. And when people say, well, I don't have any family history, they don't take into account some of the other factors. So I think this patient I would want her to do a Tyrer-Cuzick so she could know, okay. And the reason why that's really important is when you have that Tyrer-Cuzick score, it helps you get it covered by your insurance plan. I would not exclude that woman from considering menopausal hormone therapy, but I would really want to make sure that we're not missing an opportunity to find a better way or an enhanced way to surveil her.
Next question. My mother had estrogen positive, ER positive breast cancer. And for this reason, my PCP suggested I stop taking birth control when I turned 40. For this reason, I assumed I wouldn't be able to take MHT, but is that actually evidence-based best practice?
None of what she's being told is true or is in any medical guidelines. I'm being serious. Birth control is important. There's a reason why you're probably on birth control. So if you need contraception, I want you to have it. If you want to avoid hormones, there's other forms of contraception. There's a non-hormonal IUD. But the preponderance of data tells us that the benefits of that hormone therapy or that birth control far outweighs any risk of breast cancer. Your mother's ER positive breast cancer is one red flag that there's something, a family history. I'd want to say to that doctor, well, have you screened this patient? Does she need genetic testing? Right? So one primary relative, it's not always enough to kind of tip tip the boat and have you get genetic testing, but you should make sure you ask, well, what about your aunts and cousins, and ask on both sides. So one, should she have genetic testing? And let's follow this through. Let's pretend her genetic testing was positive, right? We have very clear guidelines. I often use this as an example. BRCA carriers have the highest risk of breast cancer. We do not deny birth control or menopausal hormone therapy to even those patients. We do counsel them to have their ovaries removed when they're done with their babies. We do offer them a prophylactic mastectomy, but even if they haven't had it, we don't deny them hormone therapy, particularly when they're 40. Because we know that if they're having menopausal symptoms or they go through early menopause at that age, that their risks of the menopause far outweigh their risks of hormone therapy. I think there are better birth control. I think there are certain formulations that I like better for people who have a family history of breast cancer, but she is absolutely not excluded from the MHT discussion.
Terrific. This next question, I've heard that the American Cancer Society no longer recommends clinical breast exams or self-exams for women of any age. What are your thoughts on that change, especially in comparison to screening methods like mammography or MRI?
So I think, it's two sides of this. I think it's a confusing message. It is that it's, feeling your breast has not been shown to be an effective screening method when we're talking about a public health message to millions of women, and that we don't want to send the message that that's a form of screening. There's so many false positives that come from if that is your main form of screening, right? That being said, I don't think you can meet any physician out there who cares for women who does not advocate for them to notice changes in their breasts. A lot of doctors and even cancer specialists will talk about like breast awareness, right? Versus making women feel really like they've got to do some very special breast exam. It's just, you must be aware of changes, right? Because the earlier we can, send you for then the proper screening, the better. I understand why people get confused. I think all women should be examining their breasts every month.
Okay. I'm going to get to a couple more and then check in with you on time. I am 2.5 years past a triple negative breast cancer diagnosis, suffering terribly in menopause since chemo. Stage 1, no lymph node involvement, DMX, BRCA. I don't know what DMX is, so correct me if I'm not saying
double mastectomy.
Double mastectomy, I should know that. BRCA negative, no family history. I need systemic estrogen. I cannot find a doctor to give it to me. I've been to 4 doctors, even a doctor in the Menopause Society. That's a heavy one.
So I'm sorry, this patient is how many years from?
2.5.
From an ER positive breast cancer.
From a triple negative breast cancer diagnosis.
Triple negative, yeah. So here's the thing. Triple negative breast cancer, the most common recurrence time is in the first 2 to 4 years. It peaks around year 4. By year 5, it goes down greatly, and we don't see another peak, right? So basically, you get through those first few years of being a triple negative survivor, your overall prognosis is excellent, right? Especially with very early stage node negative. So that's number 1. Number 2 is shutting down your hormones has never been part of your treatment, right? So these patients are reasonable candidates to have that discussion. Nobody's risk is 0 of having a breast cancer recurrence, right? Even if it's triple negative, I don't care what it is. The risk always exists, right? We're always going to be slightly more careful because in those first 2 to 5 years, because if you have a recurrence, right? We want to we want to minimize anything that is happening in those years. That being said, if someone is really suffering and their risk is very, very low, it is incredibly reasonable. The biggest problem is fear and lack of education in our clinicians. So what I would say to that patient is there's 3 big resources. One is, and these are all available to anybody, if you Google it, in this year, so 2025, the Menopause Society practiced Pearl on MHT after breast cancer, written by Dr. Holly Peterson. She outlines the data that there is no data on earth that shows triple negative patients have an increased risk of breast cancer recurrence when they use hormone therapy. So you can use that and bring that to your doctor. Number two, the paper that I just mentioned has very clear consensus recommendations on this exact case scenario, right? Number three, the Menopause Society is always a really great place to get a list of Menopause Society certified practitioners, but that doesn't mean that they're experts on managing really complicated menopause, right? Like, frankly, a lot of practitioners are new to this menopause party. They're signing up, they take the little test, they get their credentials, and they're great for helping like the average menopausal woman, but not everybody with that credential is great at complicated menopause. And so, unfortunately, you're going to have to be a really squeaky wheel, and you're going to have to ask around in your network, and find someone who is, willing to have that conversation. But those publications that have been recently done, I think are very, very helpful for you to then go back and say, you know what, I know you've been reluctant, but I'm going to bring you these papers. I want us to sit back. And I also say, doctor, was stopping my hormones or putting me into menopause or giving me an estrogen blocker, if that was never part of my treatment, why can we not have a reasonable discussion with shared decision making about using a very low dose of estrogen to help me with my symptoms, right? So like, that's how I would approach it. And my guess is you may have to go to more than one doctor.
Right.
Yeah.
Dr. Menn, can you talk about the risk of using MHT after ER positive, PR positive DCIS after a bilateral mastectomy? Also have CHEK2, CHEK2 genetic mutation.
Yeah. So again, this new paper that was published addresses this, and this is how we have to think of it. We always want to look at what is your baseline risk of recurrence. So somebody who has an ER positive breast cancer or DCIS, which is non-invasive stage 0 breast cancer, your lifetime risk of breast cancer recurrence mortality is widely quoted as 3%. But that's kind of a crap number because it's based on old data, and it's kind of taking into account everybody who's had DCIS, and it's not really differentiating between people who've had mastectomies versus lumpectomies, et cetera. So your risk of recurrence is really, really low after having a bilateral mastectomy for DCIS, assuming there was no microinvasive disease, that the margins weren't closed, and there wasn't high grade, disease, so any of those factors could like have a slightly higher risk, because you have to understand, when you have a mastectomy, we don't take out every single breast cell. Like, there could be a cell left over. So if you have a CHEK2 mutation, obviously those cells are at a higher risk to begin with, right? But you've done what was asked of you. You've had your mastectomy. So I tell these patients, your theoretical risk is extremely low. And I think it is a reasonable thing. And in the new kind of consensus statement, they go along in these patients. If we give estrogen alone, awesome. If we give estrogen with a progestin or something, go with a progesterone. You might want to ask your patients about DuoV. DuoV is a conjugated estrogen with basodoxifene. Basodoxifene acts kind of like tamoxifen. It protects the lining of the uterus, unlike tamoxifen. It blocks estrogen receptors in the uterus, and it seems to block estrogen receptors in the breast. And we give this basodoxifene with an estrogen, with the conjugated equine estrogen, right? And it's together in one pill. The brand is called DuoV. We don't have it at Alloy. We're trying to work with Pfizer to get it. Listening, we want to provide this for a great cash price for patients. But this is a hormone therapy that if your doctor is really reluctant to prescribe you hormone therapy, be like, hey, how about DuoV? Because I'm going to go a step further. At ASCO this year, they presented a paper on patients with DCIS who were newly diagnosed, who still had their breasts. They just had their little first biopsy. They gave them DuoV for 8 weeks, and they said, what happens here with this DCIS? And then they did their lumpectomies where they actually removed the whole DCIS. And what they showed is, in that short period of time, it was only a short period that they were on DuoV, yes, their menopausal symptoms were treated, but there was no progression of the DCIS. And the markers for the cell turnover, or, you know, how quickly cells are turning over and proliferating in terms of cancer cells, those markers were cut down in half, right?
Amazing.
So it showed that Duo-V does not seem to be stimulating the breast cells. So I throw that out there for those patients who have had a bilateral mastectomy, particularly with DCIS, that we have some data points also to show, you know. And then the other thing I love to say to a doctor who's like, won't have this conversation. If your patient had DCIS and they had a mastectomy and they were still getting their periods, would you tell them that they had to shut down their ovaries?
Right.
Would you
I
make,
love when you ask that.
would you make them take their ovaries out?
Yeah.
No. Well, that's really interesting, doctor, because when you have your menstrual cycle, your estrogen goes from 30 up to 300-400 every single month. Guess how much a serum estrogen level is on someone who's taking 2 sprays of the Evamist or is using maybe one of the lower doses patches? It's about 30.
Yeah. Yeah.
30.
Incredible.
30. So you're okay with me having my menstrual cycles with my bilateral mastectomy. You're cool with that. But you ain't cool with a tiny patch?
Right.
Give me a break.
Give me a break. Oh, I love that.
Now I'm getting mad.
I love when you get mad, Dr.
Because I'm
Menn.
hungry.
Yes, I know. I'm winding you down because you've been talking for an hour and 16 minutes straight. And I'm going to quickly say to this person who asks, do you take MHT and vaginal cream? Yes, you can take
Rachel knows this one.
this one. I can definitely and affirmatively, and I will tell you to please use both. You need your vaginal estrogen alongside systemic hormonal treatment. So yes. And you talked about Duo-V and you talked about mammograms a lot. Should I get blood work before starting MHT or to monitor dosing?
No.
Could you please give the citation again for the recent publication, RE, MHT, and risk?
Yeah, so I'm gonna put it, I'll put it in
That's
my stories today. You can
great.
share it in your stories
Terrific.
because it's pre-print. So if you just Google it, it's not gonna come up, but it is available online. And so we will share that. It's going to be in the January issue of the Menopause Journal. Yeah, so we'll share that.
Dr. Menn, you know how much I always love speaking with you. I love you as a person and a clinician. Thank you so very much. This was a conversation, I have to say, for over 5 years or 5 years or whatever now, I've been nervous to have with anybody. And in fairness, the conversation around this very topic continues to sort of be illuminated, and the WHI study continues to be a resource to look back on and say, hey, you know, as you have said, I'm glad for this because now I can kind of just like beat a dead horse and really put it down where it should be and amplify the truths that are in there. You are a breast cancer survivor. You are an advocate. I would not have wanted to have this conversation with anyone other than you. I know that we're going to continue to blow it out. And what I really wanted out of this was for people to walk away with diminished fear and anxiety and worry about what is available to them, what's accessible to them, what's reasonable for them, and what they can converse with their Alloy clinician or any other clinician they speak to about. Menopause care is nuanced care, breast cancer, breast health, and menopause care is nuanced care. Breast cancer treatment is nuanced care.
Very Yeah.
So, thank you for today, Dr. Menn. Thank you to everyone who joined us. I know that you're walking away feeling informed and supported. I want to remind you again to take advantage of today's code over on myalloy.com. It is MENN20, MENN 20. Take care of yourselves. Keep up with your screenings. We will see you next time, Dr. Menn.
Yeah, and we can keep these questions, some of these other questions. We didn't get to some of this, a few specifics, but you know, we can take them, and I like to make reels. And so,
Dr. Menn is the real queen.
so we can answer some of them, you know, also on reels and on some future stuff as well. Yeah.
Yeah. I did promise that we get to all of them, but honestly, Dr. Menn's been growing. Like I can't in good.
And I just want to look at, because it bothers me when people like come here. And you
Well,
don't need a BRCA test before taking estrogen. You need a BRCA test if you have a family history of breast or ovarian cancer syndrome. And
sorry, go ahead.
so you can kind of get your testing. We can start you on hormone therapy if you're symptomatic. And we don't exclude BRCA carriers, but if you're a BRCA carrier, we're gonna recommend you to have, you know, consider preventative things, right?
Autoimmune and perimenopause connection. That's
yes, there's a definite connection, because estrogen is a neuromodulator, it's a immunomodulator, and a lot of autoimmune conditions can worsen around this time. Most autoimmune diseases, menopausal hormone therapy is perfectly acceptable for, and can even help with some of the symptoms. Some of the autoimmune conditions have increased risk of cardiovascular disease, so we tend to go with a transdermal. The best contrast enhanced mammogram, better than an MRI. You should ask your radiologist for what your body needs.
all right. Here's a question I didn't answer, and it's and if you really want to get into it, well, let's do it. What if you don't have a uterus and in your 30s and estrogen dominant? That's a verbiage that comes up a lot.
Yep.
Due to cortisol decreasing progesterone, should you take progesterone? I have heavy periods, large clots. Go ahead.
Yeah, it's a really good question, because people are shamed. They are shamed by doctors when they say, "Oh, I'm estrogen dominant." They get a lot of negative pushback, and so like women are using words to describe what they're feeling. Let's not shame them. When your ovaries are sometimes making a lot of estrogen and you are not ovulating always. So say like when you had your uterus, you had heavy periods and you went every 3 months without a period. Well, kind of, are you estrogen dominant? I mean, sort of. Your body's making estrogen and you're not ovulating. If you don't ovulate, you don't make progesterone, right? So you remove the uterus, you take care of the problem of the bleeding, but your ovaries are still doing what they were doing. They were making a lot of estrogen and maybe not always ovulating. Because remember, removing the uterus isn't necessarily changing what's happening with those ovaries. So could you feel like bloated, breast tenderness, moody, emotional, all these things? Yeah. So could you use a little progesterone to offset that? Now the cortisol thing is a little bit more complicated, because cortisol is linked to stress. So if you've got a lot of stress in your life, whether it's from your health conditions, from mental health, from untreated perimenopausal symptoms, you could feel like you're higher in cortisol. But remember, cortisol is a very important hormone. We don't want to like be low in cortisol, because if we had that, that's called Addison's disease. That's like bad. Okay. We'd have to give you more cortisol, right? So be careful if anyone's calling you like, you know, cortisol, whatever, like be careful with that. You don't need generally special cortisol support. You should think about like, why is your body having a lot of stress? But progesterone can be used in women without a uterus in lots of scenarios.
Okay, Dr. Menn, now you've officially answered every question.
Oh, there's one more that I have to answer.
What? I missed one?
ADH and MHT, atypical ductal hyperplasia, is a common biopsy thing, a biopsy finding, and it raises your risk significantly of getting breast cancer in the future. So I like to tell these ADH or atypical lobular hyperplasia women, they're at a higher risk of breast cancer. All right. I have to treat them like someone who is higher risk. So they need enhanced surveillance. They can be offered risk-reducing medications like low-dose tamoxifen if they're not having bad menopausal symptoms. The problem is when this presents in someone who does have menopausal symptoms. They're like, tamoxifen to lower my risk of breast cancer. We can use very low doses of tamoxifen and people can tolerate it really well. So it is an option that you should know about, but you at the very least need enhanced surveillance. These patients with ADH are not precluded from hormone therapy. These are patients who I love Duovi for. Duovi as an option. But they're often told they can't even have a talk about it, but you have Now that is my last question.
Stopping you. And I want to alert everybody that Dr. Menn will be back with me for an Alloy support group.
Oh, that's right.
Yes, where we're essentially extending this conversation into,
Yeah.
yes, with patients. If you are an Alloy patient, if you are an Alloy member, this is for you. If you're not, I encourage you to take advantage of that code today.
And if you're just a skincare member, right?
And yes, you are welcome to join. You should be getting our emails. But it is exclusive to the Alloy community, and we will have Dr. Menn. I will forewarn her that we should book 90 minutes and she should be well fed prior to, so that we can continue this very conversation. That'll be on Thursday, October 16th at 12 noon Eastern time. So with that,
We're
thank
done.
you,
We're out of here.
we are out of here. Love you, Dr. Menn. Thank you
Love you.
so much, everybody. Thank you for being here and for your brilliant questions. We're so happy to bring this space to you and be there for you. Thank you. Bye, everybody.
Bye.